Well, hello, everybody. My name is Jerry Artz. I'm a professor here at Hamline University in St. Paul, Minnesota. Today, I'd like to share with you an exciting project regarding the validity testing of an abbreviated algorithm that's used to calculate something which is called the permanent whole person impairment rating, abbreviated as WPI, and we'll be talking about that a lot here as we go through. This work is a collaboration of medical personnel from California, headed by Dr. John Alchemy, and also here at Hamline University with Zach Reed, who is one of my undergraduate students. And the structure of this presentation, to give you a little bit of an idea, be as follows. We'll first define and talk about what the whole person impairment indeed is. Then we'll be talking about the critical components that is necessary to design a faster method of determining the whole person impairment. And then we'll discuss the software in the form of a Hyperapp. And then finally, we'll do clinical testing. First off, what is an impairment that occurs? Well, if you have a work-related injury, then the workman will typically undergo therapy and achieve maximum medical improvement. But oftentimes they do not return to the very same level of functionality as what they had before the injury. As a result, this is called a permanent impairment. And as a result, they can be rated, and then a settlement can be awarded by an insurance company as a result. However, the worker has to go through an exam. This is an exam that will determine a whole person impairment. 0% whole person impairment is normal. On the other hand, 100% whole person impairment, the person is totally non-functional, and a maximum settlement would then be awarded. The exam must be done by a specialized medical professional. It's very costly, it's very time-consuming. There's many questions, measurements, and calculations that need to be done. Specifically for our prototype software that we call the Hyperapp, we have chosen to rate shoulder injuries. Shoulder evaluation by the classical method, as I mentioned before, is very costly, but on average for the shoulder it requires 2.5 hours and up to 150 questions, measurements, calculations. Here, our normal range of shoulder motion for flexion and extension in the sagittal plane is displayed. All ratings are legally bound, in fact, to methods prescribed in the AMA Guide to the Evaluation of Permanent Impairment. This serves as our major document in the coding for WPI ratings. Well, what about the faster method? What is this faster method and the critical components that that are necessary? And to do this, we'll go through each one of them. There are 4 of them. The first one of these is pain. This is something most of us are quite used to. Whenever we go to the doctor's office, we have pain. We give a pain rating, 0 for no pain, to 10 for excruciating pain. Note that this is subjective, but there are objective limits. A pain level of 5 or greater will include limitations on the patient's ability to function. The second is a statement of how many ADLs the patient is unable to do. Normally there are 34 of these, but we'll ask only the most popular of these and then extrapolate over the entire 34, again to save us and the examiner some time. Number 3 is a physical exam, and this measures, again, the functional loss caused by an injury. This exam measures such things as range of motion, other types of tests as well to classify the severity of the injury. And the 4th is X-rays, MRI, CT scans, other diagnostic tests and interventions that have to be done. And based on these 4 components, we then determine what is called a RateFast Recovery Score Index, the RSSI. It's a number between 0 and 10 that defines the patient's recovery process across the 4 discussed clinical indices that we just mentioned. And the groupings go all the way from 0 for no functional loss at all the way up to 9 or 10, which is very severe functional loss. The faster method, the software, what we want to do is to take these 4 critical components, use the RSSI, and then output a whole person impairment as a result. We want to make it very user-friendly, make it simple. So simple, in fact, that non-specialized medical evaluators can use this in order to determine a patient's WPI. Hopefully, it will save time and expense and also be accurate. And we'll find out in this test. Let's now do a test. I'd like to show you the Hyperapp and how this works. So first, we have just an entry of my name. I'll just kind of go right on down the line. I pre-populated some of these, the date of birth, and also the date of the injury. And I had an injury, let's say 3 months ago. The injury part, let's say, is on the shoulder. It's got to be the shoulder, since that's the only thing our Hyperapp can do right now. It's on the right side for that injury, and I am right-handed. The pain severity, based upon 0 to 10, I'm going to claim it's a 7. Frequency, 75% of the time. And let's say that I am unable to perform full duty due to pain. I can also click ADLs, but based on what I've already entered, the ADLs are pre-populated based upon what I've entered. And if I want to change anything, then I can go ahead and do them here. Was there a pre-existing injury on the shoulder? I'm going to say yes, there was. Previous pain level was 2, 25% of the day. And let's say we did have surgery. And the surgery, let's say, was a full shoulder replacement as a result of the injury. Also, the diagnostic tests were performed, arthritis, and let's say that it's the worst kind, namely bone on bone, that comes out. Was there a scar? Yes, but there's no pain, nor is the scar tender. So I'll say no. If you want to say yes for range of motion, you can go ahead and enter those ranges of motion. If you say no, the program will pre-populate the range of motion based upon what you have entered so far. What is the estimated global loss of motion? I'll just say severe. And from this, then we can go ahead and do a submit. And immediately the report comes out for the insurance company. It was that fast, which is pretty remarkable. So it talks about essentially the subjective, surgical, objective, diagnostic testing, the impairment rating, the parts of the AMA guide that were used, all the way down here to your final shoulder claim. Let me highlight that because that's the number that we want to use. And that comes out for this particular case to be 26%. It also talks about apportionment, and all that is included into that WPI, the arthritis, pre-existing injury, and also a measurement as to how good the data was. And let's go back here. So in this case here, now that we know how to utilize the Hyperapp, now how does that compare then to the classical method? We use the data from 42 patients, and we did both classical and Hyperapp for the data input for the 42 patients. So the various RSSI groupings essentially are all then color-coded. All this is on the next slide. And so we can see the differences here between the Hyperapp and also the classical method. You can see it's grouped here into mild, moderate, severe, and then no problems at all, okay, as far as functional, but there may still have been an operation that may give you a WPI, so that also is included for both cases. So you can almost see the worst case here is an 8% difference here for the mild limitations here. It's almost an outlier because look at some of these others. There's very little difference that exists for the others here as we go. Here's a 5, here's a 3, but you can see that the others look amazingly close, very little difference. And let's look for the no functional loss at all. Okay, this slide shows the results, from the data, summarizes the average difference for each of the 4 categories, and also the standard deviation for each of the 4 categories as well. You can see mild is probably the worst, standard deviation. If you look at all of them, the average for all turned out to be very close to, what is it, 0.1% difference. It means you have as many positive differences as what you have negative differences. Not quite so meaningful, but what is more meaningful is probably the standard deviation. The standard deviation is at 2.3%. So now, what can we conclude from this? Well, first, probably the lower functional loss cases experience the greater standard deviation. And maybe one reason, we think at least for this, is because of the ADL score contributed more significantly in the lower severity cases. But other than that, they look reasonably close, but here is the key point, and that is the AMA Guide 5th edition allows a 10% difference between the two examiners as being a valid finding. Even our worst case was 8%. I even considered that an outlier, but yet that would still be acceptable from the AMA Guide for ratings between two examiners. Well, I'd like to acknowledge the research that was used for this. Both a scholarship fund and a research fund there at Hamline University. And really appreciate your attention. Thank you very much.